pressing on to the muscular system now. After the skeletal system, this should be a lot easier for you to learn the names of the muscles, particularly as the muscles often are called after the bones they're attached to. It's not easy learning the muscles though, and in the first instance I certainly would learn where on the body the muscles are. So if you can practice the pronunciation of the muscles and then know where they are in the body, you're halfway there to guessing what their action would be if you know where it is. So we will be going through the muscle systems. Do take it in bite-sized chunks and try and get the whole family involved and think about when you're washing the dishes, what muscles are you moving, and try and learn the muscles as you go. I used to have them on the back of the toilet door, the muscles of the back, and I would take 1 week I would learn the muscles of the back, and the next week I would learn the muscles of the legs. So just take it in bite-sized chunks. The functions of the muscles are to move bones, and by moving the bones they aid to help us move. We have ligaments, tendons and fascia, and the items outlined in red are important things to learn for the ITEC examination. Ligaments are very strong and have very little stretch, and they link 2 or more bones together. So if you think of the wrist and the ankle bones, they are bound together really tightly with ligaments. So the ligaments link 2 or more bones. The tendons, however, attach muscle to bone, and the most common of the tendons in the body that we know about is the Achilles tendon, which attaches the gastrocnemius and the soleus muscles to the back of the calcaneal bone. So a tendon attaches muscle to bone. Fascia is the name of all the covering of white fibrous connective tissue that we have throughout the body, and fascia might cover a group of muscles. We might have fascia on the bottom of the foot, and quite often people suffer from plantar fasciitis, and itis is an inflammation of the fascia. But muscles are made up of specialized elastic connective tissue, and these muscles fibers are expanding and contracting. That's why they need to be elastic. And in order for a muscle to move, it needs to shorten to contract and lengthen to extend. Now, what gives the muscles their stimulus to do that is a motor nerve. So, for instance, we have sensory and we have motor nerves, and if my finger wanted to sense whether a cooker hob was on or not, and it was hot, and I touched it, it would be the sensory nerves that would carry that stimulus up the brain, and the brain then would send a message through the motor nerve to stimulate an action like get your finger off the cooker because it's hot. So sensory nerves pick the nerve stimulus up, and motor nerves are what form the action. Now there are muscles work in pairs, and when one muscle is working, the other pair will be relaxing. Now when we flex our elbow, for instance, our biceps muscle is contracting. So at that time it's the agonist, and I remember that because if I contract a muscle for any length of time, it will be agony. So the contracting muscle is the agonist, and the relaxing muscle is the antagonist. So if we flex the elbow, at the time of the flexion, the biceps is contracting, that's the agonist, and the triceps underneath, which works with it, is the antagonistic. But when we extend the elbow, which is the opposite action to contracting it, we're going to extend it, then the biceps is relaxing, so at that time it would be the antagonist, and the triceps would be the agonist. So muscle moves, at least 1 or 2 muscles will work in pairs. or sometimes they will work in groups. What proportion of the body is muscle? 23% of a woman's body is muscle, where 40% of a man's body is muscle.
We have muscle functions, 4 muscle functions, and the most important of those is definitely movement. The body wouldn't move, the bones wouldn't move without the muscle attachments. So we have 2 types of movements. We have isometric, where there is tension without moving. And we can see that in the top picture here, we've got a very muscular trainer who's holding a weight static. He's not moving it, he's just holding it. But are his muscles flexed, the biceps flexed? Yes, they are. We can see that in the picture. We have a flexed elbow and the muscles are definitely working. The veins are popping out on that muscle and it's holding quite a hefty weight. That's an isometric movement. That is tension without movement. So if I was to hold a glass of water and fill it up with water, that muscle in my arm would still be working, but it wouldn't be moving. However, the arm that is filling up the glass of water would be moving, and that would be an isotonic contraction with movement. Because as we can see in the bottom picture, we've got a flexion and then an extension, a flexion and an extension. So that's an isotonic move. And as we hold the glass with our right hand, maybe to fill up with a jug of water with the left, that movement of lifting the jug over the glass, pouring it and putting it down, that's an isotonic movement. Movement with contraction. The other function is to stabilize the joints, and all the muscles stabilize the joints. We have rotator cuff muscles that stabilize the shoulder. The knee can be quite an unstable joint, but we've got at least 9 muscles attaching in and around the knee, as well as those ligaments to keep the knee stable. So all joints need to be stabilized with muscles. We also need to maintain posture as everybody sits up straight. We're maintaining posture all the time by contracting our muscles. And I don't know about you, but over lockdown, my core muscles are shot. They're not doing a very good job at all. And one of the things I'm going to have to do is learn to strengthen them, because when the core muscles get very lax, then the lower back tends to suffer. So the other and 4th and final function that we need to know about is temperature control. And the body, the muscles make us shiver when we're cold, and that shivering generates heat. So one of the 4th functions of the muscle is temperature control. So warming us up with movement when we're cold, shivering to make So let's get down to the nitty-gritty of muscle tissue and talk about the 3 types of muscle tissue. We have voluntary, involuntary, and cardiac muscle tissue. Now, generally, muscle tissue is made of elongated cells that expand and contract, a bit like an elastic band. They facilitate movement, maintain posture, generate heat, like we discussed in the previous slide. But these three types of muscle tissue we do need to understand. The voluntary muscle is skeletal muscle. So all muscles that move bone are voluntary skeletal muscles. Now they are striped or striated when you look at them in any depth, because the muscle fibers are quite clear and they all move slightly differently in contraction. When one's contracting, the other will be relaxed so that we can maintain a movement for any length of time. So muscles movement is voluntary. So that if I want to scratch my nose, for instance, I can flex my elbow, bring my hand towards my nose, flex and extend my finger so I can perform that action. Now, that is considered a voluntary movement. I've decided to do it. The brain has decided to make me do that by issuing instructions to the motor nerve to carry out that movement, as opposed to involuntary or smooth muscle. Now, these muscles can be found in parts of the body where we don't have any control, thank goodness, because we don't have to think about whether our arteries contract and relax or whether our bladder carries out filtration, and whether the kidneys filtrate the urine, whether the lymph nodes contract and relax, whether our glands secrete hormones. These are all involuntary movements. We have no control over the dilation of our pupils. That happens automatically. So involuntary muscle is smooth muscle. It doesn't have any striations or muscle fibers. It's very smooth, and it is found in places where we have no control, but movement happens. The eggs leave the ovaries and travel down the fallopian tubes to the uterus once a month as an automatic involuntary movement. So everywhere in the body, like the lymph and the glands and the hormones, they're all moving around the body as a result of involuntary, smooth movements. Now, the cardiac relates to heart. So we're talking about cardiac muscle tissue. Now, this is different. This is a combination of both of these. The cardiac has a certain amount of striped muscle and a certain amount of smooth muscle, but they're all involuntary. But that is a completely different type of muscle combination than the rest of the body. So they are your three muscle tissue types: voluntary, involuntary, and cardiac. And they do tend to have a question come up in the ITEC paper.
There are three types of skeletal muscle: voluntary, striped or striated muscle, and all skeletal muscles in the arms, legs, throughout the whole body, all under conscious control. So we do voluntarily decide to move our bodies, whether it's by an automatic stimulus sent to the brain and then a response, or whether we consciously decide to scratch our nose and send a message to the brain because we can feel an itch. And these are bundles of fibres that run all in the same direction that cause these stripes or striated muscle. And this, again, highlighted in red, shows that this is a common ITEC question. Second category is involuntary or smooth muscle. This is not under conscious control. This tends to happen automatically, whether we want it to or not. And thankfully, our urinary tract will work whether we're awake to tell it to or not. The biliary tract is to do with bile coming from the liver to the gallbladder. The blood and the lymphatic vessels contract and pass lymph and blood through them, whether we decide to or not. The ducts of glands, the alimentary canal, which is in the digestive system. The respiratory system will carry on breathing. That's voluntary and involuntary, because we can actually take in a deep breath, and that would be a voluntary skeletal move. So it's a little bit of both with the respiratory system, but definitely the eyes will dilate and contract whether we want them to, and the uterus the same. So involuntary muscle is smooth and is not under conscious control. The cardiac is unique to the heart muscle, and this is only found in the heart. This is responsible for pumping the heart. A muscle action or movement of a muscle is dependent on the energy available, the strength of the nerve impulse, the contracting time of a muscle. If we don't have adequate blood supply, then the nutrients and oxygen are not getting to that muscle, so we need to have lots of good nutrients for muscle action. The strength of the inhibitory nerve inhibits the movement to make sure we don't over move. The temperature of the muscle, we need to be warm in order for our muscles to move successfully. And the amount of waste product, for instance lactic acid, that clogs up our muscles will inhibit the movement of the muscle. Lactic acid is a chemical that is a byproduct of anaerobic muscle action. So when we're not breathing and aerobically moving, we use anaerobic type movements, and this has lactic acid as a byproduct. If you have too much lactic acid in the muscle, you'll suffer from muscle fatigue. And this is a classic ITEC question. They like to ask you about lactic acid and muscle fatigue.
We need to understand the terminology that we might use when referring to muscles and their movements and their position. Abduction is a term that means moving away from the midline. So we have a midline going right the way down the middle of the body, and that's always referred to as the midline. So an abduction is if my arms were down by my sides and I wanted to abduct them, I would take my arms out to the side, and that would be an abduction. Now, I often think that if you abduct a child, you take it away. So this is how I remember abduction is taking something away from the midline of the body. It might be your legs out to the side, it might be your arms out to the side. So that's an abduction, and we can see that clearly in the top picture on the left-hand side. That's an abduction. Now, if we go down to the adduction, a couple of headings down, adduction is adding something to the body. So in this case, that is moving towards the midline. So an adduction is the opposite of an abduction. An action, however, is what and how the muscle moves. So we talked a little bit about the different types of movements. We talked about agonistic and antagonistic and isometric and isotonic, but an action is how the muscle moves. So if we go back to talking about the biceps, for instance, which is in the picture bottom left, the biceps at the top of the arm flexes the elbow. And the action then of the biceps is to flex the elbow. Now, an attachment is anywhere that the muscle, the tendon, or the ligaments attach to the bone. So an attachment could be by fibers, tendons, ligaments to each other or to bones. So an attachment could be an origin and an insertion, because as we see with the biceps, the origin of the biceps is at the top of the humerus and the insertion is below the elbow. So I'll go in a minute to explain what an origin and an insertion is and why they're different. But for our purposes now, they are attachments to the bone. Continuing on with our muscle terminology, dorsiflexion and plantar flexion are terms that always refer to the foot and ankle. You don't hear of dorsiflexion of the arm or the head or the wrist or anything else. It's always the foot and the ankle in particular. So dorsiflexion is where we bend our toes up towards the head. And in doing that, we flex the ankle bone. So this is called dorsiflexion. The opposite of dorsiflexion is plantar flexion. It's when we point the toes or the foot down towards the floor, sort of plants the bottom of the foot onto the floor. That's known as plantar flexion. We also have two other terms that are only referred to with the foot, and that is eversion and inversion. Now, the way I remember it is that inversion is moving the end of the muscle or moving the side of the foot inwards. So inversion is moving the inside of the foot inwards, and eversion is moving the outside of the foot outwards. So dorsiflexion is pointing the toes towards the ceiling and bending the foot. Plantar flexion is pointing the toes or the foot downwards. Eversion is when you turn the outside of the foot outwards, and inversion is when you point the inside of the foot inwards. The belly of the muscle is the thickest part or middle part of the muscle. So when you're massaging a muscle and you want to have an effective treatment for a muscle that's giving pain, sometimes you can feel the pain at the origin or the insertion or even the belly. So sometimes if it's just the belly that's painful, it's worth massaging the attachments, the origin and insertions as well, and vice versa. So the insertion is the moving end of the muscle. So you're not going to be tested on the insertion and origins of the muscles for this particular exam. But if you intend to be a massage therapist, after you've learned where the muscles are and what they're called, it's worth learning their actions. And in order to learn the action of a muscle, it's quite logical to work out if you know where the origin and insertion is. So the origin is the fixed end of the muscle. So if we look at the biceps brachii on the upper arm, the origin, the fixed end, is right at the top on the inside of your humerus. So you can feel it twanging sometimes. Because it's biceps brachii, it's got two heads. So the origin is the fixed end of the muscle at the top, and the insertion is the moving end of the muscle below the elbow. So if the movement comes from below the elbow, then that pulls the lower arm up towards the shoulder. So the origin doesn't move, it's fixed. The insertion is the bit that moves. And the belly is the thickest part in the middle of our upper arm. Relaxation is a term quite obviously for lessening of the tension in the fibers. So when we relax the arm, then that's a lessening of tension in the fibers. So a flexion of the knee can be seen in this first picture on the left. These two are both flexing the knee. So it's a bend or flex inwards towards the body. If they were to lower their foot to the floor, that would be an extension. Now in this second picture, we can see both going on here. We can see a flexion and we can see an extension. So this is a flexion of the knee and an extension of the knee. What is also going on here, which is a little bit more complicated, is we have, can you see that the hip is flexed? So because there's a bend at the groin area, they have flexed the hip as well on both pictures. So this is knee flexion and knee extension, but with a flexed hip as well. So should they put the leg down to the floor, then that would be a hip extension. So definitely the picture on the left is a flexion of the knee only. There's no flexion at the hip at all. But in this one, although it is a flexion of the knee going on with the arrows and an extension of the knee, we also have a hip flexion going on at the hip in the groin area. That's using the hip flexors to bend the leg up towards the body. Muscle fatigue is when the muscle continues to contract without rest and we get a lactic acid buildup. So muscle fatigue is caused because of lactic acid buildup, and it's a contraction without rest. Muscle tension is when we have an overstimulation of the muscle fiber. So muscle tension is the normal tension that we would get within a muscle when we're moving it. Rotation is when we rotate the head and neck. So when we turn the head to the right or to the left, that is a rotation of the head and neck. Tone is a slight degree of contraction in some muscle fibers whilst the others relax. And we tend to maintain tone most of the time. That's what gives us posture, is a slight degree of contraction in some of the muscles while the others are relaxing. So then we have the term pronation and supination. And normally, pronation and supination can be seen really well on the hand. So if I turn my hand to the ceiling, that is supination. If I turn my hand to the floor, that is pronation. So turn it over and supinate your hand, so palm to the ceiling. Now imagine you have a bowl of soup in your hand. So that is supination. If you turn your hand over, that bowl of soup is prone to spill. So that is pronation. And this can apply to lots of different parts of the body. So if I lie on a massage couch, for instance, I would start to have my back done. I'd be lying prone, so I'd be lying face down. And for anybody who's done a first aid course, you would normally get somebody into the recovery position by lying them prone. Supination is if I rolled over to have my face massaged, then I would be supinated or lying in supination. We can have pronation and supination as a term for the foot as well. If we pronate the foot, we might be going over on the outside edge. That's also a pronation. If we supinate the foot, so if we're walking and we're slightly supinating, then that can be rolling over on the inside of the foot. So we have pronation and supination terms for the whole body, but generally it relates to the arm, and the arm muscles are called pronators and supinators that perform this action. So we're going to introduce you to the muscles, and we're going to start with the neck muscles. There's only 4 neck muscles that you need to be concerned about, and we need to know roughly their names and what they do. So to start with, I'd like you to repeat after me their names. We have splenius capitis, levator scapula, sternocleidomastoid, and scalenes. Now the splenius capitis is number 1, so that's top left, and the splenius capitis, capitis is Latin for head. So you'll come across lots of diseases like pediculosis capitis is head lice. Capitis always refers to the head. And the splenius capitis muscle, if you feel the back of the side of your neck, that's the one you can feel. And it extends and rotates the head. Now it's at the back of the body, so the muscles generally on the back of the body are going to the back of the neck are going to extend the neck, and that means we're going to hold it upright. Or an extension might also be taking it backwards a little bit. That would be maybe an overextension of the neck. So the splenius capitis being behind us, we can see the ear in that picture, so he's at the back of the body. It extends the neck when it moves together, both sides. So we've got one each side of the neck. And if we're going to turn the head to the right, then the splenius capitis muscle on the right allows us to extend and rotate. And then when we turn to the left, it extends and rotates to the left. So levator scapula. Now this is exactly what's written on the tin. Levator means elevate or to lift, and scapula means to lift the scapula. So we can tell that the levator scapula, it's going to do something to the scapular bone, and in this position we can see it. It's on the top medial side of the scapular bone, top corner, and it goes from the top corner of the scapula up and joins the cervical bones. Now it rotates and elevates the scapula, and it bends the head laterally, so a lateral flexion it's called. So if we put our ear to the shoulder, that is using the levator scapula. And again the other side. And it also helps us to rotate and elevate the scapula. So if you roll your shoulders, you're using your levator scapula as well to do that. So sternocleidomastoid and the scalenes are on the front of the neck. The sternocleidomastoid, now it's probably the longest muscle name, but if you shorten it into 3 sections, sternum or sterno means it attaches to the sternum right in the middle. Cleido is the Latin for your clavicle, so it also attaches onto your clavicle bone. And then mastoid is the mastoid process behind your ear. So the sternocleidomastoid attaches in 3 places: the sternum, the clavicle, and the mastoid bone behind the ear. Now you've got one on either side, and it's almost like a rope. So if you turn your head to the side, you might actually be able to feel the sternocleidomastoid rope coming from the back of your ear across to the front. It's also a muscle that gets terribly tense when we get stressed and tense. So this flexes the head. So because it's on the front of the body, it flexes the head. So we're going to bring the chin to the chest. That is a flexion of the head. And if we put it back, that's an extension of the head. And I don't know about you, but as I flex my head to my chest, I can really feel a lovely stretch on the extensors on the back of the neck. So sternocleidomastoid flexes the head when they both contract together, but also it assists in turning the head from side to side. Now the scalenes are just behind the sternocleidomastoid. So if you apply some pressure to the side of your neck, just behind the sternocleidomastoid, the scalenes can often be really painful, and they can make you feel a little bit throttled, as though somebody's throttling you. Not a nice feeling, but again, they can be very tense with people who have neck pain. So the scalenes, being on the front of the body, also assist in flexing the head and the neck with the sternocleidomastoid. They also work with the levator scapula to bend or flex the head laterally, so ear to shoulder at the side. And again, they help to rotate the head and neck using the opposite one. Now, the scalenes, as you can see in this picture on number 4, they attach to the top ribs and up into the cervical bones. So quite often when I have a client come to see me for a treatment, I can tell if the scalenes are tight and the sternocleidomastoid is tight because they lose their neck, like their shoulders come up to meet their ears. So it's like the space has disappeared. So 4 muscles of the neck then: splenius capitis, which is on the back of the neck; levator scapula, which is sort of on the side and the back; sternocleidomastoid, which is on the front from the ear down to the sternum; and then the scalenes sit just behind the neck muscles. So do practice the names of these muscles and their movements to get an idea and familiarity of the neck muscles. We're now moving on to the shoulder muscles. So these are the upper shoulder muscles. So rotator cuff muscles as well. You might have heard of that. They hold the humerus in the socket. So I'm going to say them slowly with a space afterwards so that you can practice your pronunciation. So supraspinatus, infraspinatus, teres minor, and teres major. The supraspinatus muscle is, supra means superior. So what it's telling us is that the supraspinatus is superior or above the spine of the scapula. And you can see the spine of the scapula there. At the top of the scapula, it's like a spine, and it sits, the supraspinatus, in a sort of hollow between your clavicle and your scapula. I call it the supermarket muscle because when we go to the supermarket, our shopping bags we hold just slightly abducted away from the body. So if you're holding shopping bags or going to the supermarket, it's this muscle that helps you to hold these shopping bags. So it's a slight abduction. So that means coming away from the body, probably only about 3 or 4 inches at most, because if you go further out with an abduction, then the deltoid muscle at the top of the arm kicks in. So supraspinatus is a slight abduction of the arm away from the body, enough to carry a shopping bag. And it stabilizes the humerus in the socket. So that's your supraspinatus. Now below that, on the top right, is your infraspinatus. Infra means inferior to the spine of the scapula. So here we can see that the infraspinatus is below the supraspinatus. And this one is a lateral rotator. Can you see that it attaches to the back of the humerus bone? So because of that, if you think that that's the insertion and the origin of the infraspinatus is that medial border of the scapula, then when that muscle shortens, the humerus is going to go backwards and turn. So if I rotate my arm backwards, outwards, and away from the body, that's a lateral rotation. So the infraspinatus is a lateral rotator, but it also stabilizes the humerus in the socket, otherwise it would fall out. Moving on to the teres minor, this is the lower left. It's a thin muscle. Teres minor is the smallest muscle of the teres muscles. And again, that helps the infraspinatus to laterally rotate the humerus. So they do the same job. And I tend to remember the I from the minor reminds me that it works with the infraspinatus, which also begins with an I. So these two do the same, and they stabilize the humerus in the socket. Then we have teres major. Now, when you get a minor and a major muscle, and there's a few around the body, the minor always sits above the major. So if you think of the major as being the parent and the minor as the child, then the minor always sits on top of the major. So the teres major, if you look at that one, the insertion of it is not on the back of the humerus, it's on the front of the humerus. So if we've already said that if it sits on the back of the humerus, it's going to be a lateral outward rotation. Because this one sits on the front of the humerus, when it contracts, it rotates and brings the arm forward, medial rotation, and an adduction, which means that it brings it in to the middle of the body. So the teres major is an adductor and a medial rotator, unlike the teres minor and the infraspinatus. These are four of the back muscles. The erector spinae is probably the deepest muscle of the back. And I always think it looks a little bit like I imagine a trifid to look. It comes up from the sacrum and the pelvic girdle and wraps itself in three strands around the vertebral column and attaches very close to the mastoid process on the occipital ridge. As the name suggests, erector spinae, this extends the vertebral column. So it keeps us upright and is very necessary for our posture. The trapezius is probably the most superficial of the shoulder muscles, and it's a very thin diamond-shaped muscle that covers the other muscles underneath. It goes all the way up to the occipital ridge of the neck. It comes all the way out to the acromion on the shoulder, and then as you can see, it's sort of diamond shaped. It attaches down all of the thoracic spine 1 to 12 and includes an attachment onto the scapula. So it's a diamond shaped muscle and not obviously two halves. So the upper fibers of the trapezius raise the shoulders and lift the scapula, and also help to rotate it laterally. So as you rotate your shoulders round, it's laterally rotating the scapula and bringing it backwards to help that lateral rotation of the arm. It raises the shoulders, those upper fibers, but also the lower fibers protract the scapula and bring it downwards. Then we have the deltoid. Now the deltoid gives the shoulder its shape and is an arm muscle as well. And it has medial, anterior and posterior fibers. So the posterior fibers help to move the arm backwards. The anterior fibers move the arm forwards, and the medial fibers move the arm out to the side, which is an abduction. So if we were going to carry our shopping bags, that would be the supraspinatus. But if we want to move our arm higher, then the deltoid muscles kick in. The rhomboids are the very deep shoulder muscles. They come across from the medial side of the scapula to the spine at a slight angle. We can see that they are the major and the minor sits on the top of the major, and the major's 2 times the width of the minor, so a bigger muscle. And again, as I said before, with other major and minor muscles, the minor always sits on top of the major. The rhomboids are the workers, so these adduct the scapula, so they bring your scapular bones, your shoulder bones together. So rhomboid, major and minor, they do the same thing. So repeat after me: erector spinae, trapezius, deltoid and rhomboids. So repeat after me: the latissimus dorsi, serratus anterior, subscapularis. These are back muscles. The latissimus dorsi, if you go to the gym, which is a very good way of learning your muscle names and learning what muscles do, this is your lat pull down. So it draws the arm backwards, rotates the arm medially, and adducts the arm. I don't know if you can see very clearly on this picture, but the tendon of the muscle attaches to the front of the arm, which means that as it pulls on it, it rotates medially, so inwardly, and adducts towards the midline. It's a big muscle, the latissimus dorsi, and it sort of is butterfly shaped and attaches and joins the trapezius on the back. The serratus anterior is like fingers coming out from underneath the scapula. It comes out and attaches to the top 8 ribs like a sort of serrated edge, and it helps to draw the shoulder forward, rotate the scapula, and it keeps the scapula from winging and keeps it flat on the back. It's very good for getting rid of your bat wings to stimulate and work the serratus anterior. Subscapularis is a muscle that, as it says by its name, it's underneath the scapula. And it has a sort of scapular sandwich with the infraspinatus. So the infraspinatus is on the top of the back, and the scapula is underneath, and then the subscapularis is underneath. It attaches to the front of the humerus, so it medially rotates the humerus. So it assists the latissimus dorsi in its medial rotation, and the teres major, if you remember, also medially rotates the scapula. So there are 3 more of your back muscles. So repeat after me: latissimus dorsi, serratus anterior, These muscles are in the lower back. And if you repeat after me, we have quadratus lumborum, piriformis, gluteus minimus, gluteus medius, and gluteus maximus. Quadratus lumborum, quad means 4, and quadratus lumborum, the lumborum bit means it's in the lumbar area, so it attaches to the top 4 lumbar vertebrae. And the 4 means it attaches in the 4 corners, so we can see it's sort of square shaped. Because it attaches to the last rib and the pelvic girdle, its job is to laterally flex the vertebral column. So lateral flexion is if you come down to the side, and it helps to extend the vertebral column along with the erector spinae. So lateral flexion and extension of the lumbar vertebral column. The piriformis muscle is probably one of the most useful muscles for you to know of the lower back. Over 35 years, most of my clients that have come to me with lower back pain have piriformis syndrome, or a tightness in the piriformis which feels a bit like they've been kicked by a horse. As you can see, it attaches to the sacral bone and comes right the way across underneath the glutes and attaches onto the head of the femur. So when that shortens, you can either get pain in the hip bone or it pulls the sacroiliac joint out of alignment. So anybody who gets lower back pain really needs to have a buttock massage as well to see that it's not these glutes or the piriformis muscle. So the piriformis laterally rotates the hip. It extends onto the head of femur at the back so that it helps to laterally rotate your hip outwards. And that is also an abduction of the hip. It does that with the gluteus maximus, laterally rotates the femur. The glute muscles tend to overlap one another, and the deepest one is the gluteus minimus. As you can see here at the bottom right picture, the gluteus minimus is a lot smaller. It's very much more lateral than on the bone than the other muscles. And the gluteus minimus is much more likely to abduct and medially rotate the hip than the other muscles. But the gluteus minimus and the medius tend to both do a similar thing. The medius also does a bit of lateral rotation, but I think it's easier for you to learn about abduction and rotating medially for those two little muscles. And they get sort of bigger as they layer over one another. So the minimus is the smallest, then the medius, and then the maximus is the big muscle there. And that attaches onto the sacrum, comes across over the piriformis and the other glutes, helps to extend the hip. So that means, if you're sitting down and you go to stand up, it extends the hip. And it raises the trunk as you're getting out of a chair. And it also does this lateral rotation of the femur. Just out of interest, anybody who drives an automatic car tends to have problems with their lower back because that action of the right leg going onto the pedals and off again when the left leg is not doing anything tends to mean that long term the right leg muscles will get bigger than the left, and quite often clients who come to me with lower back pain will have problems with the piriformis and the gluteus maximus because of this lateral rotation of that leg, which is not balanced with the left leg. So it's quite interesting to know your muscles if you're going on to sort of be a therapist. So we have quadratus lumborum, piriformis, gluteus minimus, gluteus medius, and gluteus maximus.
there are 4 pairs of muscles to the trunk. There's the pectoral muscles, the abdominals, the obliques, and the hip flexors, which are the psoas and the iliacus. The pecs are just above the breasts, and the pectoralis minor and major are there to draw the arm forward, medially rotate the arm, adduct the arm, and rotate inwards. So it's all the same movement. If you bring your arms out to the side, flex your elbows facing the ceiling, and then bring your elbows inwards, that is drawing them forward, adducting, inwards, and medial rotation. And if you go to the gym, that's your pec deck exercise. The abdominals are your core muscles. These are supporting the viscera. The viscera is a term attached to the squidgy bits of your stomach, like your intestines and all the organs. The transverse abdominis is very deep, and this is a core muscle. And if you pull your belly button back towards your spine, that is the transverse abdominis that you're engaging. The rectus abdominis goes from the sternum down to the pubic bone, and this is your 6-pack muscle. And as you shorten those muscles, you're going to flex your vertebral columns. You're going to bend down towards your knees. The internal and external obliques are on the side. So they're at the front, but they're on the side of your body. And if you go elbow to knee in any stomach crunch, these are the muscles you're going to be engaging. They flex the vertebral column with the abdominals, but they also rotate at the waist. So when you have a rotating twist, you've got your internal and external obliques. Now the bottom 2 pictures on the right are the psoas and the iliacus, and these are very deep. In order to massage these, you would have to go inside, anteriorly, the front of the pelvic girdle, which is virtually impossible. But these muscles help to flex the hip. They flex the hip and rotate the femur laterally. So again, bringing the femur out from the body. And flexing the hip means you bring your knee upwards. That's a hip flexion. So these 4 pairs of muscles are your trunk muscles. So repeat after me. Pectoralis minor and major. Rectus abdominis. Transverse abdominis. Internal obliques. External obliques. Psoas. Iliacus. These are the leg muscles. We're on the back of the leg. Posterior means the back of the body. Anterior means the front of the body. Lateral means out to the side of the body. Medial means it's by the middle line, so it's the opposite to lateral. These are the hamstrings. Now they're at the back of the thigh, and you have 3 hamstrings, and I want you to repeat after me. Biceps femoris, semitendinosus, semimembranosus. These muscles together flex the knee, so if you shorten them, the knee is going to come up and be flexed. And as you lengthen the leg, they help to extend the hip. So the muscle action for these is to flex the knee, but also to extend the hip. And collectively they're known as the hamstrings. Bicep femoris is obviously at the back of the femur. That's called bicep. We also have a bicep in the arm. So the one in the arm is biceps brachii. Biceps femoris is on the back of the femur. So biceps femoris, semitendinosus, semimembranosus are three muscles which make up the hamstrings that flex the knee and extend the hip. These are the muscles of the calf, the posterior lower leg muscles. Repeat after me. Gastrocnemius, soleus, Achilles tendon, peroneus longus and brevis, flexor digitorum longus, flexor hallucis longus, peroneus tertius. The gastrocnemius and the soleus are big fleshy muscles just below the knee at the back. The top one is the gastrocnemius and the soleus is just below it. And both of these muscles plantar flex the ankle. So if you imagine that you are wearing high heel shoes and you plantar flex your ankle, you'll be able to feel that these muscles are contracted. That's the gastrocnemius and the soleus. Now they insert into the Achilles tendon and attach on the calcaneal bone at the back of the foot. So the gastrocnemius and the soleus muscles extend into the Achilles tendon and attach to the bone. So that's the most famous tendon in the body. Peroneus longus and brevis. Now, longus means long, brevis means short. And these two muscles can be found on the outside, right in the middle of the side of your calf. And they travel down the outside of the calf and they go right the way underneath the foot. Now they also help to plantar flex the foot, but also if you contract that muscle, then the foot everts. So the side edge, the outside edge of the foot will come upwards. Flexor digitorum longus. Now these muscles go under the foot. Digitorum means digits, it means toes. Longus means it's very long, and if you have a look at this muscle, it comes from right up behind the back of the knee and travels down the inside of the calf, under the foot to the toes. And if we flex our toes, if we curl them underneath, that's flexing the toes. That will move all our toes and curl them underneath. That's called flexion. So that's flexor digitorum longus. Flexor hallucis longus, again, is a flexion, a long muscle, and hallucis is the Latin for big toe. So flexor hallucis longus comes from the back of the knee, down the calf, under the foot, all the way up to the big toe, and it flexes by curling the big toe under the foot, and also helps to flex the foot. Peroneus tertius is a muscle that ITEC have included in the syllabus but haven't had a question about, either orally or theoretically, since they included it. And Peroneus tertius everts and dorsiflexes the foot. These are muscles at the front of the leg, the anterior leg. These are the thigh muscles. Rectus femoris is the main thigh muscle. Now these four muscles make up the quads. The rectus femoris, vastus lateralis, vastus intermedius, vastus medialis. They are the quads, and they extend the knee and flex the hip. So if you bring your knee up to your stomach, that's called flexing the hip. And after your knee has been flexed the back, if you want to bring it down again, it's the quads that do it. So they work very antagonistically and agonistically with the hamstrings. The rectus femoris is the main man. Rectus means main man, that muscle. So rectus femoris is the main muscle that moves the femur. Rectus abdominis is the main man that moves the abdominals. This one is right in the middle, and it is right above the vastus intermedius or vastus intermedialis. Either one will do. So the vastus intermedialis sits right under the rectus femoris, and the rectus femoris is the most superficial of these four muscles. The vastus lateralis, lateral means outside, so the vastus lateralis is on the outside of the thigh, and the vastus medialis is on the inside of the thigh. The rectus femoris extends the knee and flexes the hip, and the vastus lateralis, vastus intermedius and vastus medialis help it do that as well. But their main job is to extend the knee. The sartorius is the talus muscle. This is the longest muscle that we have. It starts at the top of the outside of the hip, and it comes across at an angle and inserts just below the knee on the inside. It's called the talus muscle because we cannot sit cross-legged on the floor without the sartorius muscle. It rotates the femur laterally, flexes the knee and hip, so that in order to sit cross-legged on the floor, our sartorius needs to be nice and relaxed and toned. So repeat after me. Rectus femoris, vastus lateralis, vastus intermedius, vastus medialis, sartorius. Still on the upper thigh, these are the anterior muscles on the front of the body. We've had the quads, but inside of the thigh is that lovely area that none of us could have thin enough. These are the adductors, and these three adductors are all called by their length. We have adductor longus, adductor magnus, and adductor brevis. So longus is long, magnus is middle-sized, and brevis is short. They adduct the femur. They are known as the adductors. Now the gracilis also adducts, but if you have a look at the right-hand side of that picture, you can see a long, skinny, thin muscle like a piano string or a violin string, and that is an adductor as well. In fact, the gracilis, although it's very thin, is responsible for a lot of movements. And this is the muscle that a lot of footballers will say, I have a groin strain. It attaches right up into that pubic bone and down below the knee. And footballers in particular, if they're going to kick the ball sideways, then this is the muscle they will quite easily injure. This is an adductor, but it rotates medially, it flexes the hip and the knee, and also assists in lateral rotation as well. But its main job is medial rotation, adduction. So that's the gracilis. So say after me. Adductor longus, adductor magnus, adductor brevis, and gracilis. Now on the front of the arm, anterior arm muscles. If you're standing in the anatomical position, facing forwards with your palm facing forwards, that's the natural anatomical position for the body. So we're going to be talking about the arms facing that way. Now if you remember one word, which means helps you to remember the arm, it's brachii. A lot of the muscles from the above the elbow have brachii in them. We're starting with the coracobrachialis. This muscle is under the arm. Top left picture, it flexes and adducts the humerus. So if you imagine you have a cocoa bean under your armpit and you want to hold it there, you're going to flex and adduct the humerus. So that's coracobrachialis. The muscle top right is the biceps brachii. Called biceps because it's got two heads. You can see the two heads there attaching to the bones. That's the biceps brachii. The muscle at the top is the brachialis. Brachialis. The muscle at the bottom on the left is the brachioradialis. Now these three muscles flex the elbow. The pronator teres is a little muscle there which pronates the forearm. I don't think we've actually got a picture of it. No, we haven't on that one. But it's a little muscle right in the elbow, and it's called the pronator teres. Flexor carpi radialis is a muscle that goes down. Oh, yes, it is. There we go. It's that muscle on the bottom right. Flexor carpi radialis. Now, this is a muscle that goes from the elbow and the thumb side of the arm. You can see it there in the middle. Flexor carpi radialis pointed out and labelled there. So this comes down the thumb side. Now carpi means carpal, so it means wrist. And it's saying to you, I am flexing the wrist on the thumb side of the wrist. And it's flexing the wrist. Flexor carpi ulnaris means I'm flexing the wrist on the ulnar side of the wrist, which is the little finger side. It also helps to adduct the ulna. So adduction means that it brings the ulna inwards. Flexor carpi digitorum means that it flexes the fingers and goes down through the wrist. So the difference there between the toe and the wrist muscles is always going to be that little word carpi. If you see carpi, you know it's the wrist ones and not the foot ones. So flexor carpi radialis is on the thumb side, flexor carpi ulnaris is on the little finger side. So repeat these after me. Coracobrachialis. Biceps brachii. Brachialis. Brachioradialis. Pronator teres. Flexor carpi radialis. Flexor carpi ulnaris. Flexor carpi digitorum.
These are the muscles of the forearm. So the front of the forearm, so the palm facing upwards. The main thing to remember about these forearm muscles is that these are all flexors. So they're flexor carpi radialis, flexor carpi ulnaris, and flexor carpi digitorum. So palm facing upwards, between the elbow and the hand, these are all your flexors. Now, carpi is Latin for carpal, and the only place you find your carpal bones is in the wrist. So whenever you're looking at a question in a test paper and you see carpi, that always means that this muscle is going to be in the wrist. It's either going to be a flexor on the forearm facing upwards, or it's going to be an extensor. So the flexors all attach to the inside of the elbow. So the medial epicondyle, it's called, of the elbow. So if you put your arm in front of you and you feel that sticky out bone on the inside of your elbow, that is the medial epicondyle. And if you give it a bit of a rub slightly lower than that, you'll start twanging all these carpi muscles: flexor carpi, radialis, ulnaris, and digitorum. So the other thing to remember is that the radial bone goes down the thumb side of the body. The ulna, which is a little word, is on the little finger side of the body. So the ulnar bone goes down the little finger side. So as I'm looking at this, I can go from that medial epicondyle, the inside bone, and I'm coming across down towards the radial bone, which is on the little thumb side rather, and that is where your flexor carpi radialis comes across. Can you see that in the picture there? It's coming from the medial epicondyle of the humerus, that lumpy bit that we can feel at the elbow, and it's coming across and heading down towards the thumb side of the wrist. So that's your flexor carpi radialis. Then your flexor carpi ulnaris is the thinner one, the smaller one. Again, it's coming from that same epicondyle, but it's coming down the little finger side. So it's not crossing over so much. It's coming down the little finger side all the way down into the hand. And that's your flexor carpi ulnaris. And then in the right hand picture, you can see flexor digitorum, carpi digitorum. Now that's a thicker muscle altogether. It's got to move the fingers. So as you're moving the fingers, that's a flexion of the fingers. So flexor carpi digitorum, fingers are digits. So that's your alternative word to fingers. Flexor carpi digitorum is flexing all the fingers. So although these always seem quite complicated, I find them quite logical. Together, they all flex the wrist. So flexing the wrist joint is what they all do, really. And then the digitorum flex all the fingers. And the flexor carpi ulnaris adducts the ulna. So if you move your hand towards the body, that's an adduction. And we have a slight abduction with the radialis, but it's not really much of a movement, not like the adduction with the ulna. So we have flexor carpi radialis, we have flexor carpi ulnaris, and flexor carpi digitorum, and these all flex the wrist. The digitorum flexes the fingers and goes down, as you can see, look, into those four fingers, and the thumb is a different kettle of fish, which we'll do on later slides. So we're now looking at the muscles on the back of the arm, and the main muscle at the top of the back of the arm is the triceps brachii, and this works with the biceps and the brachialis and the brachioradialis. They flex the elbow, so when they're flexing, the triceps is relaxed, and then when we want to extend the elbow, the flexors relax and the triceps is able then to extend the elbow. Coming down to the back of the elbow joint itself, then we have the supinator radii brevi, and this does exactly what's written on the tin. It's telling us that it supinates the radial bone, and brevi means small, so it's a small muscle, and we can see that in picture number 2. So supinator radii brevi, and that turns the hand over, so it supinates the forearm. Then we have extensor carpi ulnaris, extensor carpi radialis, and extensor carpi digitorum. Now these work with the flexors on the other side, and again carpi is the middle word of these, so that would always remind you that these are going to be on the forearm by the wrist. So the extensors, unlike the flexors which are on the medial epicondyle of the arm, the extensors all attach to the lateral epicondyle of the arm. So if you have a feel of the lumpy part of the humerus as it comes to the elbow, just on the elbow there on the outside, this is where all your extensors are attaching. So if you have your hand palm down, then you can feel just before the funny bone on the lateral side, the outside edge, you've got the lateral epicondyle where all your extensors attach. So these extend the wrist. So if you pull the wrist back towards you, you should be able to feel just below that bone the extensors doing their job and extending the wrist. So we have extensor carpi ulnaris, that's heading across to the little finger side, which we can see in picture 3. And then we have extensor carpi radialis, which is extending the wrist on the thumb side. And then we have the bigger one, which is the number 5, that's extensor carpi digitalis and digitorum, not digitalis, it's something completely different. Digitorum, then we can see as we extend the wrist backwards, we could usually see it moving. So if you put your hand in the middle of the arm, you can see that one moving, and that's extending the fingers. So these muscles are on the back of the arm. These are the hand muscles. Now, if we're looking at the right hand, palm up, palm facing you, the thenar prominence or thenar muscles are on the thumb side. So they are the big prominence that you can see at the bottom of the thumb, as outlined in the picture on the left. Now, the thenar prominence is a collection of individual muscles, and these rotate, flex, and extend the thumb. So the thenar, especially for a massage therapist, does become very prominent. So that prominence or mound is the thenar, as opposed to the hypothenar, which is a lot smaller. So the hypothenar is on the left hand side, little finger side, the smaller mound, and that's a collection of muscles that form that little mound, that prominence, and that abducts, flexes, and extends the little finger. So we have thenar prominence and hypothenar prominence. These are the muscles of the forearm and the hand. Now, in all the years I've been teaching this course, which is 16 years now, we've never had a question on the extensor pollicis muscles, or the adductor pollicis muscles, or the flexor digitorum superficialis. So I would say to you, let's go through them and try and remember as much as you can about them, but we really haven't had a question in any shape or form on these muscles. So yes, all the other muscles in red, but not these. But we will go through them. Now, we talked about the thenar being a collection of muscles, and these are those muscles. Pollicis is the Latin name for thumb. So like the big toe is hallucis, the thumb is pollicis. So the extensor pollicis longus and the extensor pollicis brevis are going to extend the thumb. As we said before, if they're an extensor, they'll have extensor in front of the word. Pollicis is the thumb. Longus is that it's a long muscle. Brevis is that it's a short muscle. And the extensor pollicis brevis extends the thumb. ITEC tend to actually only ask difficult questions. So I think when you get at something like this, a muscle that explains exactly what it does on the tin, it's not too much of a difficult question if it asks you what it does. So I think this is why they don't include it in their multiple choice papers. The abductor pollicis brevis, as is written on the tin, is an abductor of the thumb, and it's a short muscle. So flexor digitorum superficialis is saying to me, I'm a flexor of the fingers and I'm very superficial. So again, it's doing exactly what's written on the tin. So I wouldn't really worry too much about these, because I'm sure if you see them in the test paper, you'll be quite easily use your logic and work out what they do. So we won't worry about these too much.
These are muscles on the hand. The palmar ponderosus is a sheet of tissue, and this is underneath the palm, and this is what gives the ridges in the palm and gives us some protection of the tendons just underneath the palm, but also gives us a structure and gives us a really firm grip of our palm. It's called an aponeurosis, and anywhere you see an aponeurosis on the body, you'll see will be a white sheath of tissue. We also have an aponeurosis down the middle of the rectus abdominis, and if you ever look at a picture of the muscles of the stomach, they're always depicted as white, and that's because you have this extra sheet of tissue which is a protection to the viscera in the body. Then you have extensor digitorum. Now these are divided into 4 tendons that pass through what they call a retinaculum. A retinaculum is like binding. It's sort of like a bandage almost round the wrist to keep those tendons tightly attached to the wrist. Otherwise they might flap about. As we get older, they might get loose and we might catch them in things. So we have this sort of binding, this retinaculum, which binds those extensors to the wrist. We have that same retinaculum on the ankle as well. Then we have flexor digitorum profundus. These are muscles that flex the fingers. But to be quite honest, we have not had questions on these muscles again in the test paper or orally for the last 9 years. But it is useful to know about an aponeurosis, and it's useful to know they're there. So repeat after me. Palmar aponeurosis. Extensor digitorum. Flexor digitorum profundus. And to be honest, when you're learning the muscles, if I say we haven't had them in the ITEC paper for a long time, if ever, I really would focus on the other muscles which come up a lot more frequently. We know that ITEC don't have an enormous rotation of questions. When they come up once, they tend to come up time and time again. So yes, by all means, do try and retain all the muscles, but do focus on the ones that we know come up time and time again.
Let's start with the muscles on the head. We have a frontalis muscle that is at the front of the head that moves the front of the scalp forward, and we have an occipitalis muscle, the occipital ridge and occipital bone being at the back of the head. So these are named after those bones. So the occipitalis muscle moves the scalp backwards, and we can see that at number 1. The frontalis muscle at number 2 on the front of the scalp moves the scalp forward. And a lot of people can move their scalp forward. I can't do it at all, but a lot of people can actually move these muscles. So the frontalis moves the scalp forward, but it also wrinkles the skin, lifts the eyebrows, and helps with giving that look of surprise or horror that we can all have sometimes. So that's your frontalis. It's got a few more actions than the occipitalis. Together, they're known as the occipitofrontalis, which is why they're sort of joined together, because they do join together, and they're known as the occipitofrontalis. Then at the side of the head, we have the temporalis muscle at the temple. Now, unusually enough, this muscle moves the jaw. Can you see that it's actually coming down and underneath the cheekbone, the zygomatic bone, it's actually attaching to the mandible. So it raises and retracts the lower jaw. So if you put your hands on the temporalis muscle and clench your jaw, you can feel that the temporalis muscle is moving. Now, because of that unusual and maybe difficult thing to remember, ITEC do ask you about which muscle on the head or face moves, raises and retracts the lower jaw. So retraction is pulling it back and raising it. So that's the occipitalis, frontalis, and temporalis. There's quite a lot of muscles on the face, and unfortunately some of them do what's written on the tin, but some of them don't. And we do, as massage therapists, massage the face, so we do need to know the muscles of the face. Most of them tend to attach to each other rather than to the bones. So like in the film with Hannibal Lecter, Silence of the Lambs, when he peeled off somebody's face almost in one piece and put it on his own face to disguise himself as somebody else. It's quite gruesome, but it is feasible, you know, that's why he was able to do that, is that these muscles attach to each other. So when we have a facelift, the muscles are literally taut and pulled back behind the ears. So it is feasible to sort of do that because they don't attach to the bones. If they attach to the bones, you'd have to sort of like unattach them to be able to do a facelift. So we're going to start with the corrugator. Now repeat after me, corrugator. Now if you know about corrugated iron is sort of creased and wrinkled. So the corrugator is found just by the eyebrows and it wrinkles the forehead. So that's your corrugator. Now, the nasalis is actually on the nose. So the nasalis. And the nasalis sits just above your nostrils and flares the nostrils. So your nasalis, not that difficult to remember, flares the nostrils. Now, procerus nasi, not quite so easy, except if you think of a rhinoceros. A rhinoceros has got a big horn on its nose. And also rhinitis is inflammation of the nose. So procerus nasi is a muscle that extends up the nose from the nasalis and wrinkles the bridge of the nose. So say after me, corrugator, nasalis, procerus nasi. So they tend to wrinkle the forehead, flare the nostrils, and wrinkle the bridge of the nose, a bit like Samantha in Bewitched. Continuing with the face muscles, we have number 1, if you can see the green line around the eyes, this is the orbicularis oculi. Now, as it says, orbicularis, an orb is a circle, and orbicularis means that it circles the eyes. So this muscle goes round the eyes. Oculi means eye. So a binocular is something that you look at with your eyes. So oculi is eye, orbicularis is around the eye. So orbicularis oculi closes the eyes. So as the muscles close together, they close the eyes. Buccinator, buccal means mouth. Buccinator is a muscle, tiny little couple of muscles that we have at either side of the cheek. So we can see that in number 2. It's the bigger of the pictures. Now this compresses the cheek against the teeth and is responsible for blowing. If you blow, you can feel these muscles. And if you whistle, that is also using those muscles as well. So the buccinator compresses the cheek against the teeth so that we don't end up being too jowly. So it's good for blowing and whistling and keeping us looking nice, keeping the cheeks against the teeth. Then we have the zygomaticus. Lovely word, I think, zygomaticus. So the zygomatic bone is the cheekbone, and the zygomaticus sits on top of the cheekbone. And it moves the mouth up, back, and out. So that actually means that we're smiling. So when we move the mouth back and out and upwards, it's bringing us a smile. So zygomaticus is all about smiling, bringing the mouth up, back, and out. So if you repeat after me, orbicularis oculi, buccinator, and zygomaticus. So taking these face muscles in bite-sized chunks, we have 3 more. The masseter is on the cheeks, and the masseter helps in mastication. So mastication is the proper term for chewing. It raises the lower jaw. It's quite a big muscle, and that's the masseter for mastication. Then we have the orbicularis oris, and again that does exactly what's written on the tin. It's an orb, it's a circle, and it goes around the mouth. Oris or oral always refers to the mouth. So if you take tablets orally, then you're going to put it in your mouth. So anything that you put in your mouth is oral, and your mouth is known as oris. So orbicularis oris is your muscle around the mouth, and it purses the lips. So if you're going to kiss somebody, then you would be pursing your lips and you would be puckering your orbicularis oris. So I suggest you go off and find somebody you know really well and pucker your orbicularis oris. Then we have the pterygoids. Silent P sounds like a pterodactyl. Pterygoids. Now, these are medial and lateral pterygoids. And the pterygoids push the mandible out and open the mouth. So that's your pterygoids, pushing the mandible out to open the mouth. Now, there are 2 of them. I wouldn't worry too much about this. We have had pterygoids in the examination, but not very often, and we've never had them referred to as medial and lateral, so I wouldn't worry about that either. So if you repeat after me, we have the masseter, the orbicularis oris, and the pterygoids. So the last few slides on the face muscles, and then we're done. So repeat after me. levator labii superioris, levator anguli oris, depressor labii inferioris, depressor anguli oris. So as you might have noticed, where we have a levator, we have a depressor as well. So levator means to lift, depress means to lower. So the levator muscles are always above the mouth or the lips, and the depressor muscles will always be below the mouth and the lips. So levator labii superioris, divided into individual words. Levator is another name for lift. Labii means lips, and if you're going to lift the lips superiorly, that means you're going to lift them upwards. So levator labii superioris is telling you where I am. I'm superior to the lips. I'm above the lips, so I'm lifting the lips upwards. So we're lifting the upper lip, and if you do it, you can feel a bit like Elvis Presley or Cliff Richards, you know, lifting the upper lip. So levator labii superioris. Now levator anguli oris is lifting the angle of the mouth. So lifting the corners really of the mouth. So again, this is raising the corners of the mouth and helping the zygomaticus, which we already know is lifting the mouth up, back and out. So the levator anguli oris is very much working with the zygomaticus to give us a nice radiant smile. So levator anguli oris. Now that means that depressor labii inferioris is telling me I depress or pull the lips downwards. I'm inferior to the lips. So I'm pulling the lips downwards, which is going to make you look really glum or quite petulant. So that pulls the lips straight down. And then we have depressor anguli oris, which pulls down the corners of the mouth. So depressing the angle, the corner of the mouth is pulling the corners of the mouth down, making you look very miserable. So levator labii superioris, levator anguli oris, depressor labii inferioris, and depressor anguli oris. So we're now on the last two muscles of the face and the last ones of the whole body, you'll be glad to know. So the first muscle we have is the mentalis. And the other one to finish off with is the platysma. Now, there is no mental reason why the mentalis should be on the chin. But apparently mental is French for chin, which I didn't know. So the mentalis is on the chin, and what it does is it lifts the skin on the chin and it turns the lower lip outwards. So that first picture on the left is the mentalis. The platysma covers the whole of the neck, and the platysma depresses and wrinkles the skin of the lower face. So it gives you your double chin, your jowly look as you get older, and the platysma is what we don't want to allow to get too saggy. So that we have the mentalis and we have the platysma. And that's the ends of all the muscles. So it's as easy as that. I'm sure you just need to go over them time and time again. Practice with your family. Pucker your orbicularis oculi. Work your orbicularis oris one at a time and give them a cheeky wink. So try and get your family involved in learning the muscles. It will help if you can just bring it into everyday life with you.
Moving on to diseases and disorders now of the muscles. You'll be glad to know that that's all your muscles now in your syllabus. And as I said before, the best thing for you to do really is to learn the names of the muscles and where they are in the body. If you can just know that they're on the arm or the leg or the back, then at least it means it'll give you a better chance of guessing what the action might be. Achilles tendinitis. Now it's an itis, so it means it's an infection or inflammation of the Achilles tendon. Inflammation of the Achilles tendon, sometimes an overuse injury associated with maybe either your shoes rubbing, new shoes, playing on a different surface if you're playing sports, or increasing the intensity of an activity, and usually on Achilles tendinitis. Adhesive capsulitis is a name given to frozen shoulder. This is a chronic inflammation of that capsule around the humerus normally, and this is really painful, and quite often it will be maybe a repetitive strain injury or a sudden movement will cause this, and this can often be extremely tender, not helped if it's rested, not helped if it's moved. Quite often it'll come very suddenly and it'll go equally as suddenly, but sometimes after years of having had it. Massage, in my opinion, does not necessarily improve it because this is inflamed. In my opinion, acupuncture is the only thing I've come across that actually will treat adhesive capsulitis. So it's frozen shoulder, it's sort of adhesed, it's stuck, and often caused by a repetitive strain injury. Atony is a term given to a lack of muscle tone. Any word that has an A in front of it means that there's absence of what comes behind. So in this case, this is saying there's an absence of tone. This might be somebody who just doesn't exercise at all, somebody who maybe has been in a plaster, might have an atony to the muscles when they remove the plaster. Atrophy is muscle wasting or lack of bulk. And again, you might get atrophy of the muscle as you get older, or again after you've had a fracture. Backache is a sort of generic term for any sort of back pain. Could be lumbago, which is inflammation of the lumbar region, could be due to rheumatism. 3 out of 4 people will have bouts of lower back pain, and over 70% of the population suffer from back pain. Bursitis is inflammation of a bursa. A bursa is a cushion of fluid, filled with fluid, that cushions between bones and the tendons, between bones and muscles. You find them all over the body, and any of them can become inflamed and painful, and that would be a bursitis. Cramp is a painful, localized, involuntary muscle spasm or contraction. A sustained contraction. We don't really know what causes it. It could be a lack of salt, could be overexercised, but cramp is painful, localized and involuntary. Fibromyalgia is a sort of generic term for muscle tenderness. You can see in the top right hand corner there a picture where they have the red dots. This is where people with fibromyalgia have this persistent muscle pain. It tends to move around. There doesn't seem to be any reason for it. There's enormous tiredness with it as well. but it does tend to be quite chronic. But they do benefit from mild massage, a light massage. Housemaid's knee is another name for pre-patellar bursitis. It's inflammation of the bursa between the patellar tendon and the patella itself. So that's housemaid's knee. These are two very common questions that might be asked in the exam. You've got lateral epicondylitis and medial epicondylitis. Lateral epicondylitis is tennis elbow, and medial epicondylitis is golfer's elbow. Now, you have an epicondyle in the elbow. So if you have a feel of the elbow, if you find the humerus bone, those little nodules either side of the humerus bone, just coming down to the elbow, are your epicondyles. And the lateral one is the one that's on the outside. Now that's the one that becomes inflamed. That's tennis elbow. And the reason it becomes inflamed is because when you play tennis, you have a lot of extension of the wrist and the lower arm. And all the extensor muscles attach to the lateral epicondyle. So it is an overuse syndrome, using excessive wrist action, and it's the outer part of the elbow that becomes painful and tender. So that is lateral epicondylitis and tennis elbow. Now if you find the other epicondyle on the inside, so palm face upwards in the anatomical position, medial epicondyle of the humerus is where the flexor muscles attach to. And this is where you get golfer's elbow. This is the medial or inner part of the elbow becomes painful and tender. And this is because of that awkward medial rotation in the golfing movement for anybody who plays golf. So medial epicondylitis is golfer's elbow. So to say these after me: lateral epicondylitis, medial epicondylitis. One thing I forgot to mention was that myo means muscle. And after we've been exercising, the stiffness and pain we might feel the next day or even the day after is because of the micro trauma to the muscle. In order for a muscle to improve and to tone, we have to have these micro traumas, and this is a tiny little tearing of the muscle fibers in the sheath around the muscle or connective tissue, and it's normal during training or exercise to have these tiny little tears. Muscle dystrophy is not normal. This is a group of genetic hereditary muscle diseases that weaken the muscles. Myositis is inflammation of a muscle. A rupture is a burst or tear in the muscle sheath. This can happen anywhere. In this particular diagram, we've got an Achilles tendon rupture. Shin splints, it's a general term for any painful condition referring to the shins, often caused by running, jumping or sprinting. It's an overuse injury. And if you ignore shin splints, you can have a hairline fracture, or it can even lead to a more complicated capsule injury with the muscle. So shin splints, very painful term for problems with the shin muscle. Usually the anterior tibialis is the one that's having problems. A spasm is a sustained contraction in response to pain. Spasticity is a term given here to the where the inhibitory nerve has been cut. This causes the spinal reflexes to keep a sustained contraction, and quite often people with this condition will have an arm that is pinned to the body in a flexion action, and although you can extend it out by force, it will not stay extended, it will flex back, and this is a problem with the inhibitory nerve. A sprain is a sudden twist or wrench of the joint ligaments. A sprain is an injury to a muscle or tendon, and you do need to know this. A sprain is to a ligament, and the places we tend to sprain our body are either our ankle or our wrist, where we have lots of ligaments, whereas a strain is to a muscle or tendon. And also we have to think about the consideration again of stress on our muscles. When we get stressed, we tend to hold ourselves tensely. Our muscles then can get stiff and painful, and the effect of stress on our muscles is to affect our posture and become tense and painful. Tetanus, also called as lockjaw, is a medical condition characterized by a prolonged contraction of skeletal muscle fibers. You can catch tetanus through barbed wire or a rusty nail, and we get given a tetanus injection so that we can avoid getting lockjaw, which used to be the most horrendous condition before we had this injection that came along. Tetanospasmin is a neurotoxin produced by the gram-positive anaerobic bacterium Clostridium tetani, and this is the infection that generally occurs through wounds contaminated by dirty nails or barbed wire in a deep puncture of a wound.